This conference will now be recorded.
Welcome in, everybody. Today we're going to be talking about chapter 21, which is going to be anaphylactic reactions. Very common emergency that we get dispatched to and provide emergency medical services for. And this is one of those things that's actually occurring more and more frequently because we're introducing more and more chemical compounds, synthetic materials that are being introduced to the immune system throughout the population. So let's dive in. These are the text pages associated with this chapter. And then these are all of our objectives that we're going to be going through. When you are studying, one of the best things to do is go over all of the objectives at the beginning of the textbook and make sure that you really recognize and identify all of the key objectives within that. There's a lot of information throughout each and every chapter, but if you really hone in on the objectives, if you're starting to struggle or fall behind, that is going to give you a good base as far as working your way through this textbook and working your way through this course. So here's our case study. We got EMTs Luke Boyce and Joy Dunn arriving at Armstrong Elementary for a report of an allergic reaction. 6-year-old Jesse Mendoza began having difficulty breathing with weakness and a rash within a few minutes of accidentally being exposed to peanuts, to which he has a known allergy. EMTs see young boy sitting in the nurse's office, swollen lips, and they can hear wheezes throughout with a stethoscope. So when we're looking at this, this is reflecting back on pharmacology when we were talking about the use of epinephrine. So this individual is starting to display those major signs and symptoms right off the bat of a possible anaphylactic reaction. So our level of concern that the EMTs have based on this general impression. So remember, within our general impression that we're trying to identify any immediate life threats. And when we hear wheezing, we know that the respiratory system is compromised. And as a result, we should be thinking that this is a high fidelity patient at this point. So the patient's body, cause of his signs and symptoms, remember from our epinephrine discussion that the allergic reaction, what's going on inside the body is a release of histamines. And as a result, those are going to be the culprits behind all the signs and symptoms that we're going to see. And then our treatment plan for this patient, airway, breathing, circulation, and then the use of an epinephrine pen. Remember, this is a pediatric patient, so we would be looking at an Epi Junior. So let's dive in deeper into the causes and reactions, that is anaphylactic reactions. So an allergic reaction, this is a hypersensitivity reaction. Anaphylaxis, this is going to be our severe allergic reaction because we can basically dial it into a mild or less severe allergic reaction and or a severe or emergent reaction, which is going to be anaphylaxis, which is another type of our shock if you reflect back on our discussions on shock. Any delay can be a result in death. There's been several documented morbidity, mortality rates from anaphylactic reactions. So when we're looking at what our immune system does, and our immune system looks for any type of culprits or any type of organisms that are entering the scene that they don't identify with. And those are going to be classified as antigens. So anything coming into the system that the body doesn't recognize and wants to fend off. So an allergen is actually a type of antigen, and the body is going to recognize this as a specialized allergen. And so it actually builds up this massive response in the event that they get introduced to that substance again. So when an individual is first actually introduced to this allergen, let's say that this individual has an allergy to peanuts. And so the very first time that this individual gets introduced to peanuts, there might be a very mild reaction to peanuts, but oftentimes we're not going to see any type of severe anaphylactic reaction that very first time. And it's because the body is identified, all right, peanuts is an allergen. So as a result, I'm going to create a bunch of specialized cells. And then as a result of that, the next time that that individual gets introduced to peanuts, that's where we're going to see that life-threatening anaphylactic reaction. Because now I have all these specialized B mast cells created in order to drop that defense mechanism when it gets introduced to allergens. So, what's causing the anaphylactic reaction? It's not the peanuts, it's the body's reaction to said peanuts. And so when I attack the peanuts with my specialized B mast cells, what's releasing from those B mast cells is what's called histamines. And histamines are going to be the culprit and the chemicals behind the severe signs and symptoms of that allergic reaction. And we can see right there, bottom tab, airway swelling, bronchoconstriction, vasodilation. Those are the three big ones when we're looking at signs and symptoms of the difference between a mild allergic reaction and a anaphylactic reaction. So when something's compromising the airway system and something's compromising the vessel tone that is producing blood supply to the rest of the body, all right, this is an anaphylactic reaction. We got to be ready to go as far as the EMS treatment. So again, this is what I was just discussing, that those B mast cells are going to be introduced into the body. So there we can see we have our B mast cells, they're going to drop, and then this is going to be the response within the system. So we can see our normal bronchiole compared to our constricted bronchiole up on the top left, and that's what's going to actually be comprising those wheezing sounds, difficulty breathing, and if it gets so bad as far as their oxygen levels go, then we're going to see hypoxia as well. And then it's going to drop the blood pressure because histamines are a massive vasodilator. So instead of having a normal blood pressure of 120/80, we could possibly see blood pressures 80/60. And then severe swelling within the facial edema as well. So in the event that we have a allergic reaction that does not involve those specialized cells that were discussed in the IgE, the treatment's going to be the same because the same signs and symptoms most likely are going to be involved. So the causes of allergens could be a variety of how they get introduced to the body. We could have injection as far as bee stings, hornets, ingestion. We talked about peanuts, shellfish are another big one, inhalation. And so this is where we see oftentimes very common mild allergies as far as dust and pollen, or contact as far as skin to skin contact. So injection and ingestion are the big ones. Those are going to be the ones that we see those signs and symptoms appear rapidly. Inhalation, depending on the allergen and how exposed they are or how violent that individual has an allergic reaction, oftentimes it's going to be delayed and these signs and symptoms are going to be relatively mild. And then the same with contact, such as a latex allergy that a lot of individuals have produced over the years. So there we can see there's a variety of different allergic reactions, anywhere from antibiotics, opioids, such as our oxycodone or hydrocodone when we were talking about Narcan, different vitamins, steroids, the list goes on and on and on. That's why it's very important when we're doing our sample history, especially when we're getting ready to give medications, that we want to make sure that we are asking that individual, are they allergic to anything that they know of? And then also when we're going through our history, if they're displaying signs and symptoms of an allergic reaction and they say that they don't have any allergies, make sure that we're asking them what they were introduced to over the last short period of time, because they may have been introduced to something just once in their life or none in their life, and then they could display signs and symptoms of anaphylactic reactions from that first and or second time being introduced. Again, as mentioned previously, the first time oftentimes we don't see a severe anaphylactic reaction. Generally, it's the second time. So the problem below that is responsible for decreased perfusion related to the effects of histamine in anaphylactic reactions. And remember, when we're looking at the term perfusion, that means that we're getting blood and oxygenation to all the cells and all the tissues of the body. So weakening and left failure of the left ventricle. So that doesn't make sense because within the histamine release, it's not necessarily attacking the pump, it's attacking the vessel tone. So obstruction of blood flow through the pulmonary artery system. We're not exactly talking about an obstruction. This isn't a myocardial infarction. This isn't a stroke. This isn't a pulmonary embolism. Vasodilation, loss of fluid from the vascular space, or inability of cells to use oxygen that is delivered to them. So inability of the cells to use that oxygen, that doesn't quite make sense because the oxygen coming in, we're anticipating that this individual has healthy hemoglobin. If somebody had anemia or sickle cell anemia, that answer would fit. But the reason of the perfusion related anaphylactic reaction is going to be vasodilation and that loss of that vascular space. All right. That does it as far as anaphylactic reactions. Remember our major, something didn't seem right here. Let me go back because it automatically kicked us to the end. Sorry about that, bear with me. There we go. Sorry about that. All right. So our scene size up, our assessment and our emergency care that we're going to provide somebody. So first off, conduct our scene size up, make sure that we are not walking into a dangerous situation because that allergic reaction very well could possibly be that there is a chemical compound that's being released. Maybe somebody mistaken themselves as far as having an allergic reaction when there's actually carbon monoxide or something else in the air. So make sure that we're looking out, doing a good scene size up as far as protecting ourselves. Conduct our primary assessment. So again, within our primary assessment, we're looking for any major life threats. How is that patient responding to us? And then treating those immediate life threats. So when we're performing that general impression, we're basically getting that view from the doorway. Is this individual sick or are they not sick? And if they're displaying signs and symptoms of an anaphylactic reaction, they are very sick. Diving into our primary assessment as far as our airway, our breathing, our circulation, oftentimes these individuals are going to need oxygen therapy because they're not setting very well with the significant bronchial constriction. So once we get to airway and breathing, if we're seeing that they're having difficulty, immediately throw your pulse oximeter on if you have one available. If it's reading 94 or less, immediate oxygen therapy. If you don't have an O2 sensor, go ahead and anticipate that those O2 senses or that oxygen saturation level is going to be low and go ahead and treat that. In the event that they are unresponsive, so their blood pressure is going to be so low or they're having such a hard time with breathing, go ahead and assist ventilations as necessary and then insert nasopharyngeal airway. With edema, as we can see in that top bullet, it's not going to help with that edema, so that could actually compromise the system. That's why I said nasal pharyngeal airway, not necessarily an oral airway. So within our primary assessment, checking that skin condition, always consider advanced life support because most EMT services, we can provide epinephrine administration, but most of us don't actually carry diphenhydramine or Benadryl, which is going to take away that allergic reaction. And then start looking for those signs and symptoms. So the pulse, we could be weak and rapid. Oftentimes that's going to be the case. We could see swelling and edema, and we could also see hives throughout the body. So sick or not sick, we arrived. This, we'll say, 61-year-old female patient, possible allergic reaction to a new medication that she was prescribed. We arrive here, significant swelling of the tongue. All right, that's a significant emergency because right within, when we're providing that primary assessment of airway, breathing, circulation, airway is now compromised. So we have to try and fix that. There we can see hives throughout. So baby was introduced to penicillin. Hives again. This is from a food allergy. So this is going to be mild signs and symptoms unless they're compromising the airway, the breathing, and the circulation. Other signs and symptoms, this could include itching of the skin, rhinitis, severe tachycardia, faintness, hives. Those are fancy terms, but basically what we're looking for is hives, itchy of the skin, dry redness. Could also see edema in different portions of the body. You know, maybe it was an injection or bee sting on the left arm. We could actually see swelling, significant swelling on that left arm or in different parts of the body. Always be ready to provide immediate intervention and transport, especially if they're displaying those signs and symptoms of anaphylaxis with difficulty breathing, with vasodilation. So be ready to give that epinephrine auto-injector sooner rather than later. Again, dive into the signs and symptoms and the pathophysiology. I'm not going to read all of these different things to you, so go ahead and dive in your textbook and look at this table and these signs and symptoms and see what's going behind, as far as behind the scenes and why this individual is actually displaying these signs and symptoms. So then, secondary assessment, diving into the present illness, which is going to be our OPQ or ST, which again is formulated within our sample history. So as it mentions, time is critical. We need to move quickly with that epinephrine pen. If we have not given it thus far and that individual is struggling, go ahead and give that epinephrine pen, especially if they say they have an allergy, they've been introduced to that allergy, when they're starting to display those signs and symptoms, it's better to give it sooner rather than later. Because as soon as that individual's blood pressure starts dropping and we give that epinephrine pen, now with that blood pressure being so low, it's going to take a little bit longer for that epinephrine pen to actually be disseminated throughout the body. So don't hesitate to give that EpiPen sooner rather than later. In the event that it's not an allergic reaction, which again, all of our signs and symptoms are pointing to it thus far. We have hives, we have bronchial constriction, we have an individual saying that they had an allergic reaction and were actually introduced to that substance. Epinephrine is a natural occurring hormone within the system, so nobody can be allergic to epinephrine. You can't necessarily kill somebody from giving somebody an epinephrine pen. So our secondary assessment, are we seeing the signs and symptoms consistent with anaphylaxis? Are they mild? Are they getting worse and or better? Because most EMS services, we're going to be carrying around 2 epinephrine pens, so we can go ahead and administer another epinephrine pen. So diving in deeper, you know, a lot of individuals are talking about that secondary assessment based on the body system being affected. So these are some great examples of questions that you would be asking within your secondary assessment, honing in on the specific body system. So patient have a history of allergies or anaphylactic reaction, prescribe that epinephrine pen, any other medications, any new medications. And again, so this is kind of diving into our sample history as well, but at the same time, we're diving specific questions within that anaphylactic reaction. And then how long has it been since you've had your last reaction? Other questions. Next, when did the patient last eat or drink? What did they recently eat or drink? Because again, that could be in the event that that caused the allergic reaction, and or if this individual has to go to the hospital and eventually in the surgery, we always want to have that information readily available for the ER staff. Secondary assessment, again, looking at all of the different systems that the anaphylactic reaction, the allergic reaction are actually going to compromise. So our skin, we're going to see hives, we're going to see swelling, we're going to see itching. Respiratory system, we're going to see bronchial constriction, possibly hypoxia from low oxygen content. Cardiovascular system, we're going to see low blood pressure. Central nervous system, we could see an individual actually start to lose consciousness and or a change in their alertness. GI issues, we could see incontinence depending on how severe. We could also see nausea and vomiting as well. Generalized signs and symptoms, we talked about rhinitis, running of the nose, urticaria, itching, dry skin, and then hives again, which is a generalized sign and symptom as well as within the skin. So if you have not done thus far, go ahead and obtain your baseline vitals. Remember, most EMS agencies are going to be responding with multiple people. And so when we're looking at the NREMT skill sheet, we see where the skill sheet wants us to take that baseline set of vitals. But normally when we're responding as a crew, we're going to have an individual who's doing that primary assessment. You know, they're the team lead, they're the primary patient care provider, and then I'm going to start directing my assistants or my secondary care providers to start taking a set of vital signs, applying oxygen therapy, and or administering an epinephrine pen in this case. So our signs and symptoms, talked about the vasodilation, so we're going to be a low drop in blood pressure. Respirations are going to be fast, oftentimes with wheezes because of bronchial constriction. And then the pulse is going to be rapid, oftentimes weak. The pulse is going to go up because the blood pressure is going to drop. So there's a compensation factor in there. And the reason why it's weak, again, is going to be from hypotension or from that low blood pressure. As far as distinguishment between a systemic and a local reaction, systemic is going to be that it's compromised in the entire body system. Local reaction, so let's say an individual puts on latex gloves and they have an allergy to latex and they're just seeing hives and swelling and itchiness strictly on their hands. So this was a contact or a local reaction. So distinguishing between those two, because the treatments are going to depend on this specific distinction. So if somebody's got an allergy to latex and they're only seeing it on their hands, it's their blood pressure is normal, their respiratory status is normal, we're not going to venture down the epinephrine route because they don't need it. Somebody who's puts those latex gloves on though, and they have a severe allergy to latex, and now their face is swelling, you're hearing wheezing, and their blood pressure is dropping. Now it went from a local reaction to a systemic reaction, and we got to be ready to go as far as providing that epinephrine pen. So the biggest signs and symptoms are going to be what the epinephrine pen is going to take away, and that is low blood pressure, vasodilation, difficulty breathing from bronchial constriction. So again, this is kind of diving into our differentiation between a systemic and or a local reaction. Usually systemic is going to be an acute onset and it's going to compromise those systems. So our emergency medical care, provide airway oxygenation therapy, suction as needed, maintain that SpO2 rate, provide positive pressure ventilations if that patient is unresponsive. Generally, an individual who's responsive at all is going to be fighting you if you're trying to actually provide ventilations. Request ALS early, and then even think about, let's say we don't have ALS readily available. Consider another BLS agency to respond, because again, we're only carrying around 2 epinephrine pens generally. And if the patient doesn't have one, then we only have 2 readily available. And always initiate transport early in the event that that patient is hypoperfusing or displaying signs and symptoms of that shock. So We've identified that it is an anaphylactic reaction. We're going to administer the epinephrine pen. Okay, that patient is going to get better, but the allergic reaction is always going to outlast the effects of the epinephrine pen. So be ready to go as far as giving another epinephrine pen sooner rather than later. So let's dive into our summary. Assessment and care, biggest thing, very similar to our heart attacks, our strokes, our sudden cardiac arrest, is recognition of that anaphylactic reaction and prompt treatment of that allergic reaction as far as epinephrine pen administration, and be ready to give multiple epinephrine pens because that EpiPen is only going to last about 15 minutes throughout the system. What the epinephrine pen is going to do is it's going to act on our alpha 1, our beta 2, and our beta 1 receptors, which cause vasoconstriction, bronchodilation, and then it's also going to provide a result in side effects as far as increased heart rate, perhaps dizziness, anxiety, a little bit of agitation. Our epinephrine pen, they come in two different types. They're going to come in our adult dose, which is going to be 0.3 milligrams for patients who are 66 pounds or greater, or our Epi Junior, which is 0.15 milligrams for patients that are less than 66 pounds. Remember, when you are using an epinephrine pen, always hold it so that your palm is on both sides and you are not placing your thumb over each end. Go through your 5 rights of your medications: right patient, right dose, right time, right route, and right medication. And then 6 is going to be our right documentation. So checking the expiration date on these epinephrine pens, the FDA has actually come out and said you can utilize EpiPens for 6 months beyond their expiration date, but always check with your local medical director within your EMS service and making sure that you're checking the window of those epinephrine pens prior to giving it. Those can be repeated 5 to 15 minutes, again, if needed. So if they're starting to display those signs and symptoms of that allergic reaction, go ahead and give it again. And those are our side effects of our epinephrine. Again, the epinephrine is going to last about 15 minutes throughout the body. So those signs and symptoms are going to dissipate. And then another key indicator is making sure that we all understand that epinephrine is not going to actually take away the culprit behind the allergic reaction. It's taken away the major signs and symptoms of that allergic reaction. Benadryl is going to take away the culprit behind that allergic reaction and or time. So we've identified this individual's got an allergic reaction. They do have an epinephrine pen, and or we have an epinephrine pen. So identify where the site is, check the site before you even remove the safety cap. So this individual had shorts on, so that's relatively easy. Remove the safety cap, grip it with your palm, make sure that you don't have a thumb over any end. Administer that epinephrine pen so that you're meeting the tip to the skin. Depress the plunger against the skin. You're going to hear that click. Wait 10 seconds, draw it straight out, and then go ahead and rub that site. So here's our case study conclusion. We got Luke and Joy. They gather that information on that initial impression of anaphylaxis reaction. Jesse does have an epinephrine pen in the nurse's office, but the nurse is not currently at the school. As Joy reassures Jesse and completes a rapid secondary assessment, including vitals, Luke confirms that the auto injector is prescribed to Jesse and administers it. So at this specific case study, epinephrine was not actually in the protocols for the 2 EMTs in this case study. Almost every EMS service in the state of Minnesota, you're going to have epinephrine readily available, and it's going to be a offline medical direction as far as a standing order. They can go ahead and give it. At the ER, they're going to go ahead and administer Benadryl for that patient, and eventually they're most likely going to be discharged. Lesson summary: difference between anaphylactic reaction, mild reaction. Any type of anaphylaxis is going to be severe, and it's going to progress quickly throughout the system. I don't know why he kicked us all the way to the end after that first question, so I apologize for that little delay there within the lecture. But that concludes Chapter 21, which is anaphylaxis reactions. Please email me if you have any questions and or concerns. I am readily available for whatever you guys need. I apologize for the weather storm on Thursday, but remember you do have those case studies, so make sure that you do your case studies. Thanks so much, and this lecture is complete.